Good evening, everyone. Welcome to our session today. So this will mainly be a feedback meeting along with a short session on probably video and communication that we can do. I think we are also joined by one of our other mentor, Dr. Balaji.
Yeah, good evening, Ma. Good evening, Dr. Ashavadani. And good evening, all of you.
Okay. Okay, so if our first candidate is ready, maybe we can jump in directly into the feedback meeting. Yes. Are you ready?
Shall I speak?
Hello.
It's me.
Yeah. Please. Good evening.
Good evening, ma'am. Good evening, sir.
Congratulations. I think, achieved a very big feat of passing. So congratulations for you.
Thank you, ma'am.
Congrats, Rohin.
Thank you, sir. It's all because of you, sir, and the entire team.
Yeah, we are very happy for you.
Yes, sir.
Yeah.
Shall I start, ma'am?
Yes, please. Maybe this is the basis of circuit. I guess everyone knows it. We all have 10 stations to cover. Because the circuit starts with clinical, I just put clinical as your first slide just to know, what you had. Shall we start from clinical stations?
Yeah, ma'am. Yeah, we can start.
Sure.
And maybe at the end of each station, we can ask others to interact, and then we move on to next station. Like that, we can.
Okay. Okay. So my name is Dr. Rohin Abraham. I gave my exam on November 4th, Calcutta, morning session. So I was roll number 1. So I had to finish all the 4 clinical stations, then the development, then history, then communication, and then video station. It was like that for me.
Okay.
So during the clinical station, while I was waiting outside, I had the time to write the format and all. So that was a big bonus for me.
Okay.
So my first case was a CNS case, and so when I entered the room, I could see a 5 or 6-year-old child who had prominent calf muscle, bilateral calf muscle hypertrophy.
Okay.
So immediately my thought came to Duchenne's muscular dystrophy. Then and the command was to do a CNS examination. So I did the Gover sign, which was positive. Then I did a full CNS examination, and then madam had asked me about the differential diagnosis. So I said Duchenne's muscular dystrophy. Then I gave other DD as a Becker's. Then she asked me about the investigations and the treatment. I was able to tell the investigation and the treatment. And in this station, I got 7 marks.
Okay, that's great. Almost full marks. That's great.
And what were the why that 1 mark they reduced? They would have given some comments, right?
Feedback, no? Yeah.
Sir, actually, I didn't get the comments sheet, sir.
Achha, you're not yet got. Okay.
No, I didn't get.
Okay. So maybe we can look into the comments and we can post later.
Yeah, I can do this.
So any difficulties you had or anything you want to tell the audience regarding this station?
Sir, actually, the signs are obvious, sir. The clinical features are obvious. So the calf muscle hypertrophy. So I think the initial inspection is very important.
But were the legs exposed for your child?
Yes, sir. The legs was exposed. Yes.
Oh,
I think
okay.
I think the boy was sitting in the chair. I told him to stand, and then I made him to walk. So immediately I saw that the child is having calf muscle hypertrophy.
Okay. So I
Then
think
I
in that, one important thing here, I think maybe we should look from a bit distance.
Yeah.
Usually the signs will be obvious. We should not straight away go and start doing the tone, power, and we might miss out
Yeah.
the important finding. Yeah.
Mm.
Uh,
So I just spent with the our formats, exposure, gate, all those other format I went. So it was very difficult to miss in this case.
good. And how were the reflexes?
Reflexes were dull, sir, and child also was very thin, and rest of the muscles were there was wasting of rest of the muscles. So this calf muscle hypertrophy was even more prominent in this case.
Okay, okay. And others, they can add to it. They can ask.
Yeah. One of them has asked in the chat box, did you have to make him lie down for the goers or did you make him squat? How did you exactly do it?
I made him squat.
Okay,
I
okay,
made him squat, and I told him to get up. So the classical goer sign was positive.
okay. And what were the
After
differences that you gave?
differential I gave Duchenne's, then I gave so first of all I told it's lower motor neuron. Then I told the differential could be Duchenne's muscular dystrophy because
Okay,
so these
yeah.
are the two DD I gave.
Yeah, so basically an umbrella diagnosis followed by
Yes,
differential. That will only
yes,
help you in exams,
yes,
yeah.
sir. Yes, sir.
Oh,
I think if it's obvious, we can restrict ourselves to muscular dystrophy. So lower motor neuron, and if it is obvious, we need not go and tell entire element localization.
yeah.
Okay.
After that, I did the tone, power, reflexes, plantar. Rest CNS examination I did.
Okay. Did they ask you to do motor examination specifically, or was it a general command of CNS examination?
I think motor examination. I don't remember clearly.
Okay, okay.
Motor
Uh,
examination.
okay. And any scar was present. They are asking any scar.
No, there was no scar. There was no scar.
And did you get time to examine whole of CNS?
Yes, sir. There was time.
Yeah.
Like I think you did motor examination. You didn't do sensory and all, no? The other parts of CNS you didn't do.
Sensory I didn't do. Sensory I didn't do.
The
Cognitive
upper limb also you were able to do.
Yes, sir.
Good.
And yeah.
Good, good, good.
Okay.
Rohin, what was the command in this station?
I think command was to do the motor examination.
They
Ma'am,
did
I
not
had the
specify
same
if it was
case.
upper limb or lower limb.
I think the command was motor examination. I didn't.
It was motor examination of both lower limbs in my case, similar case.
Yeah, yeah, must. Yeah, I don't exactly remember whether it was
Yeah.
purely lower limb or upper limb. I don't remember.
Okay.
Okay.
Okay. Dr. Rajendra, you were in the same session or a different session with Rohit?
I was in the afternoon session, same day, same center.
Okay. Maybe if it is the same station, you can also add, and whichever was different, that alone we can discuss later. Or what do you feel, Dr. Harsha? We can do
Yeah,
that.
so maybe we can combine and finish off. That's true.
Yeah, Dr. Rajendra, how was your station?
It was great. It was like easiest session for me in all of this because when looking at the child, it was obvious that there was significant hypertrophy
Okay.
and
Yeah.
Gower sign was positive. After that, despite that, they had told to do complete motor examination of lower limbs. So I had done all the muscle group examination for power and that all. And then in differential only T2DD I also gave Baker and this Duchenne.
Limb-girdle dystrophy. Okay. Yeah.
And let me introduce Dr. Rajendra. He joined. He gave first mock with us at the end, PAG, and he gave mock. and he needed some fine tuning to adapt to the MRCPCH exam. He was very quick to catch
Adapt.
them, and he was able to. So we are very happy for Dr. Rajendra. Congrats, Dr.
Yeah,
Rajendra.
It is
congratulations.
all due to you all only.
Thank you. Thank you.
Thank you.
And motor system examination on sitting or lying? We were asking.
Online. On lying on the bed.
Okay.
Okay.
Okay, Dr. Shah, if it's okay, we can move on to
Sir,
the
once the DMD has been diagnosed, would you have to complete, we have to check the CVS and all? Just for the sake, we have to say it.
No, you don't have to like
At the
in
end,
And we have to say it because of
Yeah.
Duchenne muscular dystrophy.
at the end of management, I said we have to check we have to do a 2D echo, all those things I said
Okay.
in the
just-
management, multidisciplinary approach.
Okay.
Okay. So, okay, we can move on to the next clinical.
okay,
So
next.
the second case was a cardiac case for me. In this, this was also a 6-year-old boy. On examination, the left radial pulse was a little weak compared to the right side. And on examination, there was a clear murmur in the left upper sternal area, maximum intensity over there. And then I could also appreciate the radiation of murmur to the left scapula also. So, so all the while during examination, I was verbalizing all the findings and what I'm doing. I was just verbalizing. And in the final, she asked me about the diagnosis. So I told it could be pulmonary stenosis. Then she asked me a differential diagnosis. So I said it could be ASD. Then she asked about the investigations of pulmonary stenosis and the treatment of pulmonary stenosis. So investigation, I told chest X-ray, 2D echo. I told then treatment. I told the gradient and then and treatment accordingly. So that was in that I got 8 marks. Cardiac
Oh.
session.
Congrats. Okay.
So what was it? A weak radial pulse was felt, is it?
That I could not correlate with the rest of the findings, and she didn't make a fuss about that also.
Good.
And he
Radial pulse was
not,
not
he was
might
not
not be weak. The radial pulse might not be weak then.
Yeah.
You
So
scored
I-
well in that.
all of the examiners were very kind and they were very nice.
in that actually in the exam situation, if you are able to pick out pulmonary stenosis, that itself is a good thing.
Sir, in this during the
Only
training,
the harassment because you
This-
worry something.
pardon me,
What is it?
there was no dysmorphic features.
Okay.
It just only feel like palpitating, right?
I'm sorry, I think she's not talking here, so I'm just muting her just in case.
You can mute it.
So for me, this CVS station was a little difficult. So I had gone to tertiary hospital nearby, and I saw a few cases, ASD, VSD, pulmonary stenosis cases. I actually went to the tertiary hospital and I examined those cases. So that was little helpful for me.
I
Yeah.
think that practice is very important. So
Yes, sir.
seeing those cases, going to a tertiary setup, somehow you have to, because these cases we don't see regularly on a regular basis unless we are
Yes,
in
sir.
cardiology.
Yes, sir.
So we have to go somewhere and definitely learn. Yeah. So any other suggestions you want to give, Doctor?
Dr. Rajendra, was it the same CVS case for you or was it different?
I think it was different because age was little bit higher than 9 or 10 it was.
Okay.
And there was pansystolic murmur in my case.
And location?
More towards third or fourth intercostal space, parasternal left side.
Okay. So what DD you give
I
them?
gave VSD as my first DD
Okay.
because there was no evidence of any cyanosis.
Okay. Okay. So how were the questions? So
Questions were
anything?
mainly what are your differentials for this? So other than VSD, I gave ASD as differential, but I had gave only two DDs, ASD and VSD.
Okay.
Then
I think pansystolic murmur has three differential diagnoses, isn't it? MR, TR, and VSD.
Yeah.
Yeah.
VSD and mitral regurgitation will go very close. Actually, in my exam also, I got a pansystolic murmur, and he was a big child actually, more than 10 years. And it was difficult to initially localize also which area I'm hearing very well. So it was a pansystolic in the lower parasternal, even in the mitral. I gave a combined DD, which examiner accepted. Actually, they are expecting a differential diagnosis. So far, what I am understanding, both the cases, they are not expecting the exact diagnosis. So even if you tell the exact diagnosis, they are telling what is the differential diagnosis. So prepare your differential diagnosis for each station. And anything else, Dr. Rajendra, you want to suggest?
I was not able to give good DDs. That's why I lost 1 marks. I think on this.
Still, someone is a okay. One of them has asked in the comments if any of you gave running commentary and was it okay for the examiner? Like pallor is present, no cyanosis. What have you guys observed? Did anyone of you give running commentary?
I gave running commentary, madam.
Okay, and the examiner.
Yeah, examiner was okay.
Okay.
Rohin, did you give running commentary even for your just for your general examination part, or even for the CVS examination that you were doing?
For all the clinical station, I gave running commentary.
All.
Yeah.
The best.
All the clinical.
Only if you're sure of your clinicals and whatever, you can definitely like comment on it openly. But then, especially in CVS, because you don't know what murmur you're hearing, where you're hearing. Because children are all very thin built, you can hear the murmur in all the 4 areas. You want to localize where is it. It will be better if you refrain from, commenting directly about it. Once you correlate and you can, do it, then you can probably comment.
If you're very sure of it, you commit. Like the calf hypertrophy, no? You are very sure, you comment about it. And similarly, important positives which might be having an impact in your diagnosis, you comment. Don't keep on giving everything. No, like we have
Alex, sir, I think you had told us once in one of the classes that for the general examination part, it is safe to give a general running commentary because you might forget some of the findings. But for the main station finding, it's better to do it silently and then
important positives, important negatives. So that alone you give. Don't keep on telling everything. It might irritate the examiner. So important positives. Suppose clubbing is there, tell clubbing there itself. Maybe sometimes while summarizing we might miss it. So like that. So if you feel cyanosis is very important, you comment there itself. Don't keep saying no icterus, no pallor, no cyanosis, no edema. So when you keep talking too much, then examiner will say, okay, keep quiet and examine. So that's a problem. So better give the important findings alone.
And one of them wants to know if you had any difficulty with the language when you went to your center, or was it okay to talk in English, or did they expect you to talk in the child's language?
Actually, language was not a problem. I think they can understand. Most of the bystanders, parents can understand what we are saying and communicating. So language was not a problem. Even examiner was also helping. So.
So you were conversing in English and most of the time in Bengal in Kolkata?
I think I spoke in Hindi also. Hindi.
Okay.
A bit of Hindi.
Okay, in the local language. you mean.
Yeah.
Okay. Okay. So
There was translator available, and sir told to speak to in Hindi if you can talk. Otherwise, there was translator also there.
So before the exam, the 12 candidates were in a room, and the chief examiner had come to our room, and they said, if you need a translator, we can provide. So that was not a problem.
yeah, but the problem is we will waste our time.
Yeah.
Time is very short. Only see 1 minute will be over for giving the mark sheet, introduction, rapport building, understanding the task. So you will have only 5 minutes. So in that, if you have a translator and all, I think you lose time in that.
I think you can show sign language also.
Yeah.
They are able to pick up that sign language.
And the recent marking scheme, there is no marks for communication, if I am sure, na Dr. Shodhini, the management they are giving marks. For communication in examination, clinical station, there is no marks for communication.
Though the mark sheet that's available in the website shows rapport and communication style in clinical station, that has been removed. Recently, it's been changed to management planning. Post-COVID, I think they shifted from communication to management.
We are concentrating on the management. Communication, just build a small rapport, 1 or 2 questions, wish them, and move on.
So the child will cooperate with you also. That's the
Yeah, that is enough.
And then third station, Dr.
Third station was abdominal station for me. I don't remember the age of the child. The child had a grade 2 clubbing and hepatosplenomegaly. And the examiner asked about differential diagnosis. So I gave all the differential diagnosis about infection, malignancy, storage disorders and all.
okay.
So and the examiner was repeatedly asking me what would you like to tell the parents. So that I didn't give a proper answer. Then she asked me investigation, and in this station we didn't discuss the treatment. So I got less marks for this. I got 6 marks in this
Okay.
station.
Okay. Maybe 3 minutes is too, not enough time to discuss everything.
Yeah, maybe when the comments sheet, once it comes, we can look into it. So he wanted, so once the examiner is asking again and again, it means that he wants something specific. So
Yeah, but I could not get what the answer was.
here the common theme is they are expecting the differential diagnosis. So far what we have seen, no, all the 3, the differential only they are expecting. And prepare one question, as Dr. Rohin said, advice to the parents. So I think in addition to investigation, in addition to the management plan, then the differential diagnosis, then advice to the parent. What advice will you give to the parents? Okay, so I think that will be good. Okay. And Dr. Rajendra, your abdomen
Had
station.
also similar case, but I felt like spaces are somewhat hemolytic, and I had gave vast number of DDs. Examiner didn't give any, and he asked for management for all those DDs.
So it was a hemolytic anemia.
I felt like, because there was somewhat malar prominence, not that much obvious, but there was some, and the pallor was also there. So I had gave that DD, but it was not clear cut, and examiner didn't confirm anything. And he
Jaundice was there.
no, there was no jaundice.
Okay. Clubbing was not there. Huh?
Clubbing was there.
Achha, clubbing was there. Okay. Because in thalassemia we don't expect clubbing, right?
Though, so I was not clear about my diagnosis. So I had gave many DDs, and they asked about management of all the DDs. So I couldn't give in detail, and I also got only 6 marks.
Okay. Seems like 3 minutes was too much time for you. They asked management of all DDs.
I think maybe you both had maybe the same case, na? Hepatosplenomegaly with some clubbing, and
Yes, sir.
it was difficult to give a what examiner was expecting. Maybe examiner was having a diagnosis in hand, so he was expecting something, and we were not able to give. Okay, doctor. Okay, so we can move on to the next. Any other?
Someone has asked, what differentials did you give?
Because there was no history available. With hepatosplenomegaly, I also gave infectious diseases, hemolytic anemias, storage disorders.
Okay. So the usual abdomen differentials that we'll give, you gave all those probably. Okay.
Okay, so here I think the technique of examination. So once we are unable to come to a diagnosis, no, so make sure at least you do the systematic examination, get your 4 marks from that, and the discussion part, try to give some meaningful discussion, so that as Dr. Rohin and Rajendra, na, so 6 marks you got. The rest 2 marks, I think. In the differential diagnosis, the issue would have been there. So whether you are able to put together the findings for an appropriate differential, so that's where the marks would have been down. It's
Clinical
okay.
reason.
It is possible out of the 4 clinical stations, no, so 1 or 2 stations will be like that only. Okay. Okay, doctor. So there some other were asking, was the child, any child uncooperative, whether all children were above 5 years?
All children were cooperative, sir.
Okay.
What differential diagnosis other than hemolytic anemia and storage disorders, other than that, anything else that can be given if the child has a hemolytic facies?
Okay, with hepatosplenomegaly, you can give the general DDs. Your top differential will be based on your hemolytic facies, so your hemolytic anemias. And then other hepatosplenomegaly DDs you can give, like infections, metabolic disorders, storage disorders, all those. Because they don't expect exact diagnosis.
So can I add one more point?
Oh, hello, sir. Dr. Prasanna, he is also one of our mentors. He has joined. Good evening, sir.
Good evening.
Good evening, good evening, Parag sir.
Good evening.
One thing is you may not even get hemolytic phases in some cases. So we should not always think in that term. Sometimes the child may be well transfused, and so we may not get a classical hemolytic phases also.
Yeah. Someone has asked, was the spleen massive? Like, I think they're probably asking which was more palpable, liver or spleen. Probably the question is like that. And was there ascites?
In my case, there was no ascites. I think the liver was around 3 centimeters below the right costal margin, and the spleen was around 3 to 4 centimeters. Not very massive spleen.
Okay.
There was no ascites. In my case, I could not appreciate any hemolytic phases. There was.
Because in abdomen, I would feel the chronic liver disease, IBD, those are the things where clubbing we often see. Okay, doctor.
One of our candidates has posted all the differentials in chat for hepatosplenomegaly with clubbing without jaundice. Whoever has doubts in DDs, please defer. Okay, maybe we'll move on to the next clinical station. Next would have been other station, no?
Yes, ma'am. The next one was MSK station. And I think this was a 10-year-old or 12-year-old girl who had multiple deformities of the hand, wrist. Okay. And she had flexion deformity of the interphalangeal joints and flexion deformity of the wrist. Okay. So usually I started with the screening questions. Then went on. Then I did a PRMs, so to see whether any pain is there. She also had mild swelling also on the wrist. So I did a PRMs. I just touched for a warmth, tenderness, all those things, and then I went ahead with PGALs of the upper limb. And after that, madam asked about the differential diagnosis. So I said polyarticular JIA, or it could be psoriasis, but there was no any skin rashes as such, but I gave DD of psoriasis. Then madam asked about the investigations. I gave all the investigations, including eye examination, all those things. Then treatment, multidisciplinary team approach, physiotherapist, all those things, occupational therapist, school license, so everything I told. So in this station, I got 8 marks. MSK
Okay.
station.
Good. What was the command that you got?
Command was, I think, examine the upper limb.
Okay.
Acha, it was not said as MSK.
I think I don't remember. It was MSK station, sir. It was MSK.
So
And
mostly,
examine the upper.
in Indian setup, na, so it must be a polyarticular JAA only. Since you have got marks, they were expecting the same. So, so thing is, we have to remember to ask those 3 questions in the PGALs. Suddenly, in clinical, shifting to ask those 3 questions, suddenly we might forget, and we will start examining. No? So that is important. Any swelling, tenderness were there?
Swelling was there, sir, but it was non-tender.
So for that alone specifically, did you do any local examination? You had time?
I look for warmth, I look for tenderness, and then there was no tenderness, so I went ahead with PGALs.
Okay.
Full PGALs with upper.
And regarding questions, any difficult questions like newer medicines, anything they specifically ask?
No, sir. They asked about treatment. I
Straightforward.
gave the, yeah, I gave the gentle.
Dr. Rajendra, yours others was?
My case was different. I had a small child with coarse faces, which are typical of mucopolysaccharidosis. But there was no vision loss, and he asked me about which MPS is it. No mental retardation was there. So it is, I think, Hurler, but I was not able to tell that in exam.
Okay.
I told only MPS, and I told my findings like hepatosplenomegaly was there, and there was swelling over both hands, fingers of both the hands, and there was like mucopolysaccharide deposition all over body, and changes were there. And they asked me just to do general examination of that child. That was my question.
Okay, so how did you proceed with general examination? You
First,
started
I
with
looked his height. He was short for his age. Then it was typically grossly coarse faces were there. Then father also told me, though when examiner was on one side, father told me that he couldn't hear.
Okay.
But I was I was trying to talk with child, so father told me that he couldn't hear.
And you checked for the gait.
Yes, I checked the gait. I was not able to describe what gait it is, but it was abnormal gait.
And
I examined abdomen also. Yes.
CVS, you were able to check the CVS
I
abdomen.
was just able to auscultate in CVS. There was no appreciable murmur.
And short stature, any maneuvers you were able to do, or because time management was?
Because it was general examination and there was so much to examine, so I was not able to work up on short stature. Because it was clear on examination on first look that it is MPS for me.
I think that clinical experience is very important. Seeing more and
But
more.
yes, yes,
It
when
will
I told what is on first impression, I told MPS earlier. Then they asked me why are you telling? Tell the detail of the examination. Why you are telling that it is MPS?
Yeah.
And
So
then they asked for the
try to
detail.
tell the positive findings first, and then they always expect the differential diagnosis. They don't want you to be like a consultant, no, giving straight away the diagnosis.
But I was not able to give proper differentials for mucopolysaccharidosis because there was nothing. I said other storage disorders.
Yeah.
Like
Sir,
double storage. I only told that MDDs.
Yeah, Dr. Tanushree, what you wanted to ask?
so while commenting on a child with short stature, how do we comment? Would we first say that this is a disproportionate short stature with short limbs or short trunk, like that, and the differential diagnosis could be MPS, skeletal dysplasia, something like that? Or what do they expect, the examiners?
Yeah. Yeah, Dr. Roshan, you want to add? I think if the command is short stature, then you have to classify it at the end. See, this child is short and he appears to be thin or obese, because short and thin becomes nutritional, or short and dysmorphic, then it becomes separate, or short and disproportionate, then it becomes dysplasia. So that classification at the end you have to give after doing all the examination. Okay.
And short and obese is endocrine.
Yeah, yeah, yeah. And Dr. Shahin is asking, do we need to measure in beginning upper segment, lower segment, or shoulders? That's what Dr. Rajendra, you didn't have time for measurements and all, na?
Yes, yes, I didn't
There's
have
another
measurement.
question.
It was just
About
obvious
Not
from
a clear-cut short stature approach. No, this was a general physical examination and proceed. It depends on what command is given, what you have to do.
And we will not be able to measure in this, because see, lot of, as Dr. Rajendra said, no, lot of things has to be done. He has to do general examination, then he did abdomen, he did CVS. So it's tough. Um, so at the end, maybe see short stature maneuvers also, it was difficult. Then only measurements. But if it is a short stature, then try to at the end try to measure the height at least. Then if possible, lower segment. Okay. Okay. So some other questions have come.
Any growth charts were provided? Someone has asked.
no.
Okay. And did any of you say, I mean, did you say congenital hypothyroidism as one of your DDs?
Yeah, I think Dr. Naresh has
It
given.
was quite big for that because there was no mental retardation and age was near about 9 to 10 years.
Okay. Older kid. Okay. Again,
But
Dr.
remember one thing. There is a kid in Bombay who is older. He that
She's 10 years old, I
yes,
think.
and that child is a hypothyroid, congenital hypothyroid. She's 10 years old, and that child is being kept again and again for the exams. And that child is around 10 years, congenital hypothyroidism. She'll be very short.
Yeah, so Navi Mumbai, if you go now, then I think you might get that case.
So don't think that it is maybe too old for that age, but you can put it in your DDs. That they don't want the definitive diagnosis. They want how you interpret the clinical signs and how you put together the clinical signs and give a differential diagnosis or a diagnosis, and then your investigation and management plan for the mother. So parents. So that's how they go about. If it is a straightforward diagnosis, you miss, then they may cut 1 mark. But if you give an umbrella diagnosis, then that is fine.
Okay, so good. So we can move on. If everything is okay, we can move on to the next.
Yeah. One of them is asking if we can ask the examiner which system to examine. That may not be relevant because examiner wants to know if you know which system to examine. So you cannot,
If it is a separate system, they will say do the CVS. In a general, you cannot ask the examiner which system. So he will say do the relevant system examination. Do a general examination and relevant system examination. There you cannot go and ask, sir, which system. So I think
In my CNS case, which was Dusen, I asked, should I examine CVS? Then examiner told me, no, just do complete motor examination of lower limbs only.
yeah.
So I focused on completing my neurological examination only.
Yeah. While examining, did you ask about mental retardation history wise?
no, we cannot.
No,
We cannot ask. Questions are only. Dr. Rajendra, you can answer that.
no, I didn't ask, but it was obvious from behavior of child that he is not mentally retarded.
Yeah. So we can make a assumption of the mentality. Some you can ask one question while building rapport. You can say if a CP child, no, you can obviously pick up the sub mentality, but we cannot go and ask history questions in clinical. Only in PGALs only those 3 questions you can ask. Okay.
Sir, for mentality, what question we can means in a summary somewhere we have to mention. So what we have to mention, like it is like child is average mentality or sub mentality. What word we have to use that time?
You can say submental, no? So child or delay, the child's development appears delayed. So like that you can tell. And I would like to do a proper detailed developmental assessment while completing. No, I would like to complete my examination by doing a detailed development, plotting the centiles. So like that you have to tell. Okay.
I think you can say when you observe the child today while or interacting when you were interacting with the child today during your examination, you observe that the child was submental, like that. Like whatever you observed during the examination, you'll have to tell. Child was very agitated or looks submental, was not cooperative, whatever you felt was, that can put forth points for your own differential diagnosis that you can tell.
Okay, ma'am. Thank you.
Okay, next station.
So next station was a developmental station. In this, I got a 2.5-year-old child, and the command was social assessment. So on history taking, the motor milestones were normal, and the language was around 9 months. And on assessment, the child was not responding, and the child was banging on the wall, and like that. And the social assessment, I got around 1.5 years.
Okay.
After that, examiner asked me about the differential. I gave autism, Rett syndrome, Angelman syndrome. And then in this, then he asked me about the investigation and treatment. I said an entire investigation, the CBT, all those treatment, multidisciplinary team approach, everything. So I got 11 marks in this.
Great.
So 11 out of 12, right? That's good.
History and all, whatever you taught, I just did that, sir. So during that free time I got during the clinical station, I wrote down the developmental that history format, and then
Yeah,
it was
that's a good.
almost.
I also did the
easy for me.
same like you. I also got the clinical station first. So when you are sitting outside, you don't know what clinical station you will get. So
Yes.
I started writing for my development and history, what all questions to ask and all. So you can do that. That's a good thing. So was it only social or was it cognitive assessment, Dr. Rajan? Dr.
For me, it was social assessment. Social assessment.
Only social.
Yes, only
So
social assessment.
language also was not done.
But yeah, but in history take the language development was around 9 months.
Okay. But social assessment, it will be like more of questions, na? So
Yes,
how did
more of questions.
you try to assess? Were you able to assess something or only question asking?
Only question asking, sir. So she was not responding. And she was banging the wall. So I asked the examiner. I asked the mother what all she can do. All those things.
Okay. Okay. So,
Okay.
You
Yeah.
asked to the examiner only, no? Child was not there.
Role player.
so after assessment will be done with the
assessment,
examiner, right?
examiner. Yeah, assessment with the examiner.
One of them wants to know if you had time in assessment. Like at the end of the assessment, did you have time to sit idle?
No time to sit idle. It was just touch and go.
Hmm. But it might have been a bit difficult in the sense that usually language you have a lot of things to assess. You have expressive, receptive. So all those things are out now. Only social. And in social assessment is very difficult. It will be like more of asking questions to the examiner. And, okay, good, good. So it came to 1.5 years, right?
Social assessment 1.5 years, and language was 9 months.
Related to autism only the questions were, right?
Yes, sir.
And you didn't get any specific neurological diagnosis, only the autism. Cause for autism, anything in history you got?
No, sir.
Okay, okay.
I have not mentioned anything in the notes, sir, so I don't remember.
What is that? Dr. Anjali has asked, did you ask makers of autism? Markers, is that? Markers, probably signs like rigid routine, behavioral disturbance. Is that what you're asking, Dr. Anjali?
Yes, ma'am. I wanted to ask like all that markers of autism. Do you ask in the history here or on the assessment part? Because I thought hello,
Yeah.
after only social assessment, we have a lot of time pending. So that because we have 9 minutes, it won't take up 9 minutes to do only social.
But it seems like he had enough time. What about Dr. Rajendra? You also had the same station. How was your experience?
In my case, I had to assess along with social language, and that also I had to assess.
Okay.
Like I asked mother about some questions like rigid routines and that. Then she told me to ask those in assessment.
Okay. The role player said.
Yes, to role player, not to mother.
No, who said the role player? The mother said.
Mother said.
Okay.
Then it was like child was not responding, and I had told sir that I would involve mother, and then I would do that. Then I was able to tell that it was ASD, but sir was continuously asking me the genetic syndromes associated with ASD.
Okay.
I told about Rett syndrome, but sir told no. Sir was expecting something else that I couldn't tell. Piyush Gupta sir was there only as an examiner in this station.
Okay. And what was your child's age? Same 2.5 years, is it?
I think it was same, but
Okay.
what was written in assessment I couldn't remember at present. It was boy only.
Okay. History and assessment were similar to what Dr. Rohan said, is it?
Yes, it was similar. It was the same child, but in assessment I think language was written or not, but I had assessed that also.
Okay.
Yeah, maybe afternoon they would have made it more complex.
Maybe
So
time was lot,
you
so
got
they
how
had.
much? You got how much,
Got
Dr. Raj?
9 marks.
9, huh?
Yes.
Sir, in like a developmental history, we should ask like this behavior concern, or we should only assess in assessment.
Yeah, you can ask, I think. It's not part of the development domain. Na? So, like social assessment is different. You are not going to ask questions related to social. Na? So, you are not going to ask about feeding, playing, dressing. That you need not ask. But autism related questions you can ask. One or two you can ask. No problem.
I
And
think
we,
that
if we, yes.
You will not be sued if you ask. See, if the script it doesn't have question, the role player will not tell. That's all. So they will not penalize you for asking questions related to autism. Just you are spending, is saying, don't ask questions. So even if you ask, the role player will not tell you because it will not be in the script if they are not telling. Okay.
And we found some while taking history, we find some features of autism. So we have to ask about the ADHD also, or if we are getting autism, then we have to stop there.
In the behavioral disturbance, you can ask one question: is he always restless?
So we should ask both things like is there any behavior concern or separate questions for autism as well as the ADHD?
One question you can ask, and then maybe if she says that yeah, doctor, he is restless, then you can elaborate on that. Does he make careless mistakes? Does he doesn't wait for his turn? Like that, you can elaborate. But initial one question.
Okay, sir.
Oh.
Thank you.
One of our another candidate has posted DDs for autism spectrum, the most common ones probably. And like they posted Fragile X is like an important associated one. Maybe your examiner was also expecting you to tell Fragile X syndrome as one of your differentials.
As well as Down.
Yeah, Downs
they
also.
told no about Downs. I told Downs, but sir told no, it is not associated with ASD.
Okay. And one of them has asked, can you please tell more about cognitive assessment? I think cognitive assessment is both speech and language and social put together.
Down mainly learning disability may be there.
Sorry?
Downs may have learning disability more other than the autism.
Yeah, even our regular RET, I think we will not miss it. Even the tuberous sclerosis, sometimes you can have Fragile X. I think all of you have mentioned Fragile X. I think other syndromes, maybe some Williams, Angelman, I think all they have mentioned. So we can, but problem is, you should prepare and go. There suddenly telling might be difficult. So maybe you can prepare these questions. Suppose autism scenario will come. So prepare a list of causes of autism. Okay. So that you can tell. Okay. We can move on to the next thing.
And next station was the history station. In this, I was told to take a history of 15-year-old girl child from grandmother, and so in the first admission for septic arthritis, they are taken IV antibiotics for 2 weeks at hospital, and then 4 weeks oral antibiotics at home. So in the history there was poor compliance poor compliance with antibiotics. Then there was family issues. Then the child's studies were affected. So like that, and then they asked about the complications. So I said limb-leg discrepancy, psychological impact, and the causes for recurrent septic arthritis. So in that I told it could be wrong antibiotic, wrong dose, non-compliance with the medication, all those things. So this was.
So the diagnosis of septic arthritis was already given in the scenario, right?
Yeah, it was a septic arthritis was there, And then after around 6 weeks, the child again came with right-sided hip pain. Second time.
So this is in a separate place or is it the same place?
Same place.
Same place again it has come.
Yeah, second episode. Same place. Septic arthritis.
Okay.
I think recently a lot of acute diagnoses are being asked in history.
And how much you got, Rohin, in this?
In this 10 marks, sir. In this, the most important thing was non-compliance, sir. That 4 weeks of oral antibiotics, the patient was non-compliant with the treatment. So he asked me about the cause. So he was happy when I said that there was non-compliance with the antibiotics. He was happy.
It's not like you make a diagnosis. So diagnosis, they are themselves giving straight away. It's a case of septic arthritis.
Yes.
Not resolving. Why it is not resolving? So
Yes,
the
yes.
background history, so that you picked up. So that is good. Picked up the poor compliance. The background issues. You can mute
Dr. Shraddha,
you can mute her.
trying to mute her, sir. I'm not able to mute her.
Achha.
Dr. Shraddha, okay, she's gone.
Dr. Sabri, good evening. So,
Sir, good evening.
from our another mentor, Dr. Sabri.
Hello, sir.
Yes, sir. Like, what was the diagnosis given, Dr. Rohin? They told septic arthritis frankly, or it was? Hello, madam.
So in the stem, it was given the child had right-sided hip pain, right-sided septic arthritis in the stem.
They told septic arthritis. Okay,
The
directly.
septic
Okay.
Yes, yeah. And the child was given IV antibiotics for 2 weeks in hospital, followed by 4 weeks oral antibiotics at home. So I had to take history from the grandmother. There was some family issues, some I think divorce. Then her studies were affected, all those things. And they asked me about the complications and the cause for this recurrence right-sided septic arthritis cause.
Okay.
So
I think if the case is an adolescent, definitely there is some point in heads or in the family to be unmasked, and most of the patients it is very clear. An adolescent, I think we can straight away think there is something there.
Yeah.
Okay. Good. Okay.
And how much you explored the heads? Adolescent.
I almost asked all the questions, sir. History, whatever was there in the format, I asked everything.
Good. Dr. Rajendra, what you got in history? Same.
History, they didn't give any specific diagnosis. They give like 6-week right hip pain, and I had to take history from child herself.
Oh, you didn't have a grandmother accompanying?
No, I had to take from from child herself directly. And septic arthritis was not given prior to this. I had asked differential. I had asked history related to differential diagnosis. Then, in that case, also she had received 6-week treatment before coming again to this hospital, and she was on post-operative day 2 or 3. She told me that there was pus collection, and she was operated 2 days back only.
Okay.
One mistake I did that I took role player as a patient herself because it was similar age to the role player. So I assumed that my patient is obese. So I had also given SCFE as my DD because it adolescent obese girl. So that was negative because I didn't ask about weight in history. I took like this is my patient. That was the mistake I did.
Okay. But you would have given a few differentials, no? That
I had given many differentials, but I had explored all the DDs, and in further history, she told me like she operated 2 days back only.
Okay.
Okay.
There was first collection that was sent for lab examination.
Oh,
And did you have any issues with the compliance?
No. She told me that she was taking it regularly, and in heads assessment, she was drinking occasionally. And there was one more thing in heads assessment that was significant, but I couldn't remember it at present.
Okay.
okay.
These issues with family, all that was also there for her, like mother, the parents.
No, she told me like she lives with her grandmother. There is no mother. That was the case.
Okay.
Mother was not there, and grandmother was taking care of her. Financial issues were there with family.
And in the questions, like how much we have a septic arthritis guidelines, right? So how much questions were from the guidelines direct?
They asked mainly on management. Question was, what are the reason that this child is not responding to the treatment? So I told about non-compliance, wrong choice of antibiotics, or resistant organism.
I think all
Or
these
wrong
were in
diagnosis.
the guidelines. Yeah, they were in the guidelines actually.
Sir, I didn't read guidelines, but I
Yeah.
told all this only.
But these points were there. Suppose the child is not responding, what should be in your mind? So you have to start rechecking everything. So look for the pus collection, and even after then, whether you are giving the right antibiotic, whether you are dealing with the right organism or a different organism. I think those things matter most.
And one more mistake I did, like I was in so much hurry that I may get less time. So I completed my history very fast. And with first bell at 9 minutes, I was like at completing my history itself. So I had so much extra time, and I then asked some questions which I forgot. That also was negative for me in this.
And how
So how much marks?
I scored less 6 only.
I think for students who are attending this session, if there's a single joint involvement, the differential is either if it is acute case, it is septic or post-traumatic. Rarely it can be crystal arthritis. Again, crystal arthritis is not that much common in primary. Crystal arthritis is not more common in children. So you can stick on to septic or post-traumatic arthritis if it is single joint. In addition to JA or articular, I think these are more in the top differentials. And if it's an obese child, female child, again, this alcohol, everything can fit together into avascular necrosis as well. AVN is the differential, you can have it here. And slipped capital femoral epiphysis is one differential for an obese female child, which you can have, particularly if there's hip involvement. But in this case, I think the pus is a very clear pointer, it's a septic arthritis. So alcohol, I think it is a part of Head's history. There is some stressor in the family, so she is into alcohol. All these things are fitting into your diagnosis.
Yes. Sir, there was a history of fever for more than 6 weeks, and fever was persisting despite antibiotics. So before she told me about pus, I asked in detail, and I asked questions related to JIA. But when she told about pus, I gave only one differential on that basis, that septic arthritis. But she might have been told like don't tell about pus initially, so that we ask questions related to other DDs. They assess us on it. So she didn't told me initially. She told me anything you want to tell me more about this. Then she told me about
okay, yes. So that is one question which you can always put at the end of a history. Is there anything important which you would like to tell me if I would not ask? Like that question could be a very important question at the end of the history. So something which we may miss also, the role player is kind enough, then he may tell us.
Yeah, I got a similar polyarticular J only. In that I asked, and he said eyes are red. My child's
Right.
eyes are red. That was a
Okay.
conjective, which then I added it.
So there will always be a hidden agenda, especially in history.
History, yeah.
Okay.
And for others who are listening to this, oligoarticular is a differential of less than 5 years. Usually, you go beyond teenagers, it is oligo is less commonly seen, so it's not usually a disease of that age group. And if it is single joint, always septic and trauma should be the first differential. Then only you can go for other differentials. Particularly if it's an acute history, then think about septic and post-traumatic.
Okay, doctor. We can move on to the next.
Next station was a communication station. So this this scenario, the mother wants to give antibiotics for asthma exacerbation. So in this case, I drew a diagram of the airway. I showed the pathology. Then I told the mother how the steroids decrease the inflammation. I reassured her. I told about the red flags. And in this case, in this scenario, I was not able to summarize.
Okay.
So yeah, so total I got 7 marks in this station.
That's a good score.
Yeah. So here the important thing is how you practice. So for communication, you have to practice. And most important, did you finally prescribe antibiotic or not?
No, sir. No.
So,
I
give
reassurance red flags I give.
Yeah, so it will be the same scenario. Sometimes they will come refer me to a dermatologist or anything. So if it is not indicated and if you finally agree, then you're going to get less marks. So you have to somehow convince. So we have this mnemonic, WRDA for this only. So you have to first assess why she wants antibiotic. Then you should try to reassure. So what Rohin he draw and try to reassure. So why and reassure. Then D. So what are the drawbacks? Suppose we give antibiotics. I think you have to talk about the drawbacks. Then alternatives. Then finally you tell the red flags. I think that you told. So that's why everything you told correctly.
In this case also I told about the side effects of oral antibiotics and all side effects.
So Dr. Rajendra, you got the same?
Yes, I got the same. Mother was asking like, if you are giving steroids, that will increase the chances of infection. Why you are not giving antibiotics? Previously also he received antibiotic for similar case.
So how did you tackle?
I told that look, there is inflammation in his airway, and to reduce that inflammation we are giving steroids. It is not going to increase chances of infection. It is just help. It will help in decreasing inflammation and decreasing the distress of child. And for
Was the mother angry?
yes,
Was the mother angry?
not angry, but she was not coming out of that point and asking for antibiotics again and again, and she was convinced in very last minutes.
And sometimes they need not agree also. So there you can arrange another meeting with the consultant. So
Yes, I also told about that, but she was finally convinced.
Okay. So how much you got, Rajendra?
I also got 7 on that.
Good. So some of the practicing of communication stations, in our group, it is helping. So you're able to follow the protocol, which the examiners are actually liking. So the initial introduction, rapport, then clarify the role, asking for attender and permission, then final those summary and giving the leaflets. I think those are all are helping out in getting good marks.
Yes, sir. Otherwise, communication was my biggest fear before starting preparation. But I thought both the communication session I did very well with the practice.
7 out of 8 is a good score.
Good, good. Next, Rohin, second communication.
So second was breaking bad news to father about ambiguous genitalia. So in
Oh,
this case, we have practiced this so many times, but I got less marks on this. The role player was emotional when I told about this one. The genitalia looks different, so the role player become very shocked, sad at the same time. So at that time, I paused for some time, and then I asked the role player, "Shall we continue?" And then I told about all those testing we have to do the testing, salt testing, BP monitoring. I did not draw a diagram and show about the adrenal gland and all. I got less marks on this.
In Breaking Bad, they might not be in a position to listen.
Yeah.
Not
Yeah.
me.
So I didn't summarize. So I got less marks.
So how much they give you?
I got 3 marks on this.
oh.
So I think in the remarks we have to see
Yes.
where
Yeah. Once
they,
it comes, I'll share.
they might have been thinking. So here I think they will be looking into the empathy part.
Empathy.
Sometimes in exam we will be very we will be a bit restless to finish off the scenario. So there they might be looking into the empathy part, how empathetic. So let's look into the other comments.
Was the baby sick in NICU or was it only ambiguous genitalia?
It was just ambiguous genitalia, madam.
Okay. And Dr. Rajendra, it was the same scenario for you also.
Yes, it was same scenario, and father was emotional with the news that sex is not clear of the baby. So I gave enough time to him, and I took that time as an opportunity to how to proceed further.
Yeah.
I only told about few tests. I didn't tell much and I told him that we will arrange again meeting in next session to tell you in detail. You can bring any other relative with you. With him, we can discuss. And I also told he asked me when I told about gene test karyotyping. Is it our fault that this child is due to this? Then I had seen one video for the same communication scenario on YouTube. So they say it is good question. So I did the similar, that this is good question, but it is not your fault. We are just checking that baby is having genes of male or female. And the role player was much happier after the session when after all the stations were complete. When he met outside, he was even extremely opposite to what he was on the session, and he gave me thumbs up that you performed well.
Okay.
Good, good. How much you got, Rajendra?
I got 7 on that also.
Okay. 7 out of 8.
I
Thanks.
think that video helped you a lot.
Yes, first
London,
communication video I seen of that scenario only.
the London School pediatrics video, no?
Yes, yes.
It's very nice. The lady speaks very nicely. So the 2 parents will be there in that video, no?
Yes, in that video there are 2 parents.
So there the empathy is important, and giving them hope most important. So not to tell everything is gloomy. So giving them hope is very important in Breaking Bad, in leukemia.
So your voice has become muffled.
Okay. Am I audible now?
Now it's better.
Yeah, I think empathizing and giving them hope and support, talking about that we are here and we will get into finding a solution, support groups, attaching to the support groups. I think those are very important. So good.
That they are adding first line that there may be swelling around genitalia, and that is why it
Yeah.
may not be clear at present, and it may subside in next 24 to 48 hours, and we may able to tell that your child is normal after that. So I copied that video perfectly, I think.
Good.
I think some of the questions were already answered when you were discussing your station. One or two questions more is, did you mention about CAS, congenital adrenal hyperplasia, when you were talking?
No, I didn't use any medical term. I just, because there was no fixed diagnosis, there were multiple DDs and I couldn't explain all DDs to father. So I just told we are doing some initial investigations, and whatever may come, we will discuss according to that only.
Okay.
That's a good way when in communication when you're still investigating. So it is better to say that we are still in the process of investigation, and we'll have another meeting like that.
We can move on to the next. Rohin, next.
Sir, next station was a video station. This was a 3-year-old child with a mild tachypnea and abdominal distension. And so I told about abdominal distension, and the child was in distress also. So he told me, examiner told me to tell all the findings, what history you would like to take, and then differential I gave intussusception, volvulus, pyloric stenosis. Then after that, he asked me about the management of intestinal obstruction. And so I told about NPO, IV fluids, NG tube, IV antibiotics. And then I told about multidisciplinary approach. So in this, I got 6 marks, video station.
So that was 6 out of 6, ne?
Yes.
Good. Video station is about the emergencies, how you routinely manage. So if you are into the ICU setup or in the hospital setup, you will be able to clear it. Any difficulties you faced?
No, sir. Actually, in this case, the child was in distress. There was clearly abdominal distension was there. So it was some kind of intestinal obstruction, some surgical problems. So
okay.
I didn't have any difficulties, sir.
So here you were prompt in bringing the surgeon into the picture.
Yes, sir. Yeah.
So that is important. So the initial stabilization part you were able to say, and
Yes,
then
sir.
bringing the
Yes, sir.
surgeon as early as possible. So that
Yeah.
was. Dr. Rajendra, you got a similar video? Or?
Yes, I got similar video. There was vitals were given before the station, and the child was also having tachycardia and tachypnea. So ma'am also asked about what you want to comment on that basis. So I told tachypnea might be due to metabolic acidosis associated with it, and then management of intestinal obstruction like feeding tube, continuous NG drainage, IV fluid, and then involving surgeon.
You are in intensive setup, right, Dr. Rajendra?
Yes.
So it will be easier for you.
Yeah.
So they gave how much marks for you?
6.
Yeah, good. So both of you got 6 marks.
That ma'am was quite good to give 6. I think she might have given 6 to all.
Yeah, but that is the whole essence in MRCPCH. If you are a good examiner, you have the checklist, and whatever is given in the checklist, if you are going to tell, you get your full marks. So that's how it goes. So okay. So Rohin, next video.
The next video was around a 3-year-old child with ataxic gait and upper limb tremors. And they also showed about vesicles over the back. So they asked me about the causes for ataxia. So I told about chronic and acute and chronic causes. And then DD I gave a post varicella cerebralitis. Then they asked about investigation. So I told no investigation is needed, but you can send varicella titers. Then treatment, I said no treatment is needed. It usually resolves by 3 to 4 weeks. Then I told about multidisciplinary team approach, occupational therapy, school liaison, psychologist. And this station I actually finished a little early, sir. Around 1.5 2 minutes early I finished. Then I was waiting there. And yes, sir. In this station I got 5 marks. In this station, actually, I told unknowingly I told about physiotherapy. So he asked me why you need to give physiotherapy to this child. So I said, and physiotherapy is not required. So that must be that he reduced 1 more.
Okay.
So did you bring intracranial space occupying lesion in the history to rule out red flags?
Sir, actually, the classical that vesicular rash was there of chickenpox. Yeah. So I told directly diagnosed, but in history I asked everything, sir, about fever, all those things, fever, appetite, all those things I asked. Development.
I think the red flags you should keep in mind. Suppose the vesicles are not there, I think they will expect not to miss the tumor. So that's good. And one more thing, I think what Roshan says is sometimes you have to say no investigation, no treatment. So sometimes they will expect that also. So you need not put all the I will do the MRI brain, I will do this, that. No. Sometimes it's not needed. You have to say wait and watch. Even that one more video keeps roaming around the Bell's palsy. So there also what investigation? So no investigation. What treatment? No treatment. It will resolve on its own. But maybe eye care. So that part alone you have to support them. So like that. Only if it doesn't subside, if it persists, then we have to go for imaging like that. Dr. Rajendra, you got same?
Yes, sir. I got similar video. They asked me what specifically would you ask in history, and in examination also they asked me what would you look for, and I told about the signs of raised ICP. And in investigations, I told as such, as it is varicella cerebellitis, no investigations are required. But if there is any sign of raised ICP or anything, then I would like to do MRA and involve our consultant for the same.
I think that's what important, whether you are a safe doctor, whether you are not missing out the red flags. So whether you are not doing that, that's important. So how much you got, Dr. Rajendra?
I got 6.
Yeah. So that is very
I also had almost 2 minutes after all the questions were complete. Sir and I both were sitting idle during that time.
Yeah. So video station, everyone finishes our talk very fast, right? Any other questions you have for the speakers?
What one of them has asked is, were you able to find out the gate, or was it difficult to find out what type of gate it was in the video?
It was typical ataxic gait. Very obvious.
Okay. And TDs, what TDs did you give?
DDs I gave ataxia telangiectasia and other ataxia only. Ataxia telangiectasia and one more this Friedreich's ataxia. I give only 3 DDs.
Acute and you give both acute and chronic. Okay.
Okay, anyone has any questions to the candidates? Like regarding how last minute preparations were, any exam tips that you guys want to ask them? Yeah, one of them has asked tips.
I think my abdominal examination station patient didn't had clubbing. I didn't remember perfectly, but I think there was no clubbing. I mistakenly told my patient had clubbing, but I think he didn't had. And age was around 12 years.
Yeah.
Okay. So, and one more important point advice I feel tips is, do not take baggage. See, everyone, one station or two station, definitely you will be stuck. So you might get less marks. So don't take that and affect your performance for the other station. So do other, if you are prepared very well, I think you will do most of the stations very well. It's just one or two stations, sometimes one clinical, one other, or sometimes one communication may not go your way. So don't feel for that. Try to give your full percentage. So that's what I would say. And other questions, Dr. Harsha, I think the other questions are there.
Yes, sir. So for video, they've again asked were the varicella lesions obvious along with that ataxic gait, or was it difficult for you to find out the lesions?
Yeah, this ataxic gait was a video, and this rash was a photo.
Sure, okay.
Varicella vesicles rash was a photo, so it was obvious, very obvious.
Okay, okay. A few looks like very last minute desperate questions like how was your last minute preparation? Were you able to finish the entire mark BT, entire guidelines? Did you guys read how much did you complete of the guidelines? Those are the questions that they've asked.
I think some points about your preparation.
So actually, I started my preparation from around March. Then I joined at Target MRC PCH, 6 months course. And during the course, we were able to do this whatever cases I got. I think we had done in the our 6 months course. So and we had did lots of mock exam. I took the mock exam also. So most of the cases were repetition. And then a clinical station, I made my own format. So that was very important. Then I went to tertiary hospital. I saw a few cases, cardiac cases. And that's all. Books wise, I read some Mark BT. Then Kidder notes I had taken for history taking, all those things. And then before the exam, I slept for around 8 to 9 hours. So sleep was very important. And then day before the 1 or 2 days before the exam, I just revised the format. I didn't do any detailed reading. And another important thing is that during exam, when they give the exam dates and morning or evening session, you have to be very careful. During our exam, when the senior examiner had come in our room, there were 13 candidates. So actually only 12 candidates are allowed. So we took out this one, our RCPCH letter, and one of the candidates' exam was on the previous day, November 3rd.
Oh my God.
And the examiners were very kind that he took the exam in the evening session.
Oh.
So you have to check
No,
your dates.
no,
And
he didn't. He was not able to
revise.
do in evening session also.
Oh, like that. Okay.
Because examiner told if one of the candidate doesn't come, then they can
Okay.
fit him in this.
Okay.
But all the candidates came in evening
Okay.
also.
Okay.
Despite that, they were trying to accommodate, but finally they didn't.
Okay.
That was really gross.
Yes.
Difficult, no, because you cannot accommodate, no. So all 12 stations will be
Yeah.
10 plus 1. I think 11 stations will be there. I think, or
Stations.
12 candidates, not 12 candidates.
Candidates, 12 stations will be there.
12 stations. So and everyone has paid 1.5 lakhs plus. So who will forfeit? No? Not that.
Sir, it is 1.75 now.
1.7.
So it's so costly, no? So it's difficult to forfeit and. So I think what Rohin says is the suggestion is like clinical, there is no role player practice and all. You have to see real cases, maybe out of your experience, or you go to a tertiary setup. All the others, I think you practice, you can easily get through. So most of the scenarios are repeat and you can adapt. Some variations will be there, you can adapt to that scenario, but once you keep practicing, it will be easier. So these are the things. And in target MRCPCH, 6 months of practice, I think it might be a huge drill for Rohin.
Definitely, sir. Definitely.
And, you had a good group actually to practice with others. So that
Yes, sir.
and we have another contrasting person candidate, Rajendra, who joined late. Although he was having the experience, he had the experience, but that fine tuning to MRCPCH. So that I think Rajendra can tell. That last minute preparation tips Dr. Rajendra can give.
Yes, sir. Sir, I was preparing, but I was not able to give dedicated time for my MRCPCH preparation. And when I was practicing with my juniors or my wife, I was not able to,
Yes, please.
I was not able to assess my presentation, and so I took mock test with with target MRCPCH, and then I came to know that my preparation is completely out of the track.
Like he was seeing with patients, he was talking in Hindi, right? Dr. Rajendra was talking in Hindi,
Yes,
but
because
the patient in the role player is going to talk in English. So that transition, that fine tuning alone you needed, so that we were able to give.
yes, sir, I was taking histories daily, but I was not taking those in English. I tried to take in English with some patients, but I was not able to do that in hospital setting. So after mock test, I was like, why I paid this much amount? I am not ready for the exam. But when I started with you to prepare, then finally I think with 1 or 2 sessions itself, I thought I can do with, if I prepare for these 20 days with all of you, then I can definitely do this. And finally, I was able to do it very
Good, good. And we are also going doing our mocks. So whoever is going to prepare for your exams now, if you want to do the mocks, so we are happy to help you out. So and any last minute like this, any sessions, personalized sessions also we are ready to do. So you can contact Dr. Harshavardhani for that.
Sir, very much thank you that you arranged those sessions depending on my duties, because I was doing duties even on those days, and you arranged sessions so that I can attend all the sessions with ongoing duties. That helped me a lot. Otherwise, I could have paid again 1.75.
Yeah, so that was, I think, the credit should go to Dr. Prasanna sir. So he was very much concerned. See, this boy has paid this much, so he needs that fine tuning, and we caught you. So that was good. And anybody wants to do the long course also, 6 months, so you can start from now. So preparing early will always help. So you practice, no? So then once you enter there, it would be like walk through. So that I think Dr. Rohin will accept. So that practice is important. You can always contact us for help and Dr.
Sir, study partner is must, I think. With mentors also, we need study partner, so that because mentors will take class for 1 or 2 hours, and we need to practice even at home also.
Yeah, true. So how much time, because after you started fine tuning yourself, how much time did you put into preparation every day? I think that's what people want to know. They specifically asked your experience, Dr. Rajendra's experience in preparation.
For those 20-25 days, I had stopped duties at other hospitals, and I was doing duties at only my Max hospital. And other than duty hours, I was preparing only, reading or presenting stations with my wife.
Okay. That way spouses help a lot. No, I used to do clinical examination on my spouse too. Practice, yeah. Okay. So as much time as you can put in a day, other than your work, to practice will help. I think that's what Dr. Rajendra is also trying to tell you,
Yes.
especially
There are
close.
no other option if we have only 20-25 days left.
Yeah.
But on last 2 days, I didn't read anything. After going to Kolkata, I was just enjoying with my cousin.
Instead, maybe you guys can just revise your formats, your protocols, whatever you want to do last minute. The formats for history, development, all those in the last 2 days. That should be helpful. Okay, anyone else has anything to ask or discuss? Okay, maybe if yes. Yes, Dr. Subayan, do you have anything to ask? Sorry, because it
Yes, ma'am. So I have a doubt. Like if we get a CVS case in a post-op sternotomy scar, now there is no finding, like no pallor, like no cyanosis, no clubbing, even no murmur, and apex video also in the same side, right position. So how should we do our DD? Like is a post-operated case of complex heart disease, cyanotic or acyanotic, we can't say. Maybe a cyanotic, maybe acyanotic for like PhD or HD to closer. So what should we actually say?
so for median sternotomy scar, and if the child is pink or acyanotic now, you have the basic DDs, no? All those shunt lesions like VSD repair, and then regurgitation repair. Those only will tell us DDs. Whatever the DDs for median sternotomy scar and child is acyanotic, all those you can tell everything. If the child is cyanotic, then you'll tell complex congenital heart disease. But then you can correct VSD with an open rib cage. Any shunt lesions, VSD, ASD, PD, all those can be done with median sternotomy scar. Your regurgitation lesions can be corrected. So all those can be told as DDs because there is currently no findings that you're telling. But some of them might have a residual murmur. A short systolic murmur can be heard. Yeah, especially common in post, because most commonly seen as VSD and or AVSD, and most commonly corrected ones are those. They are usually associated with short like mitral regurgitation residual murmurs. Those can also be there. I think if we have a pediatric cardiologist with us, Dr. Murtaza, if you want to add anything.
Yeah, you are quite correct, ma'am. Like post-op, if we are not getting, the child is a cyanotic, not getting any signs and symptoms. So maybe if they want to give some lesions, residual lesions can be there, even residual VSDs can be there. Then residual AV wall, as ma'am was saying, residual MR and all can be there. So that only has to be picked up. And if you're not getting any finding, then give the like blanket like diagnosis we have to give. Post-operative, most likely shunt lesions. AV canal defect, VSDs, ASDs, that way.
Okay, thank you, Dr. Murtaza. Okay, I think the feedback itself took 2 hours. Maybe we can do our practice session on some other day. I'll definitely announce a day when we can come back and do the practice session together. Hope all your doubts are cleared. If you have any other doubts, please do post in our group so that we can clarify those doubts also. Thank you, everyone. Thank you for joining us today.
Thank you. Thank you.
Thank you. Good night.
Thank you, ma'am.
Good night. Happy New Year.
Yeah, Happy New Year, everyone. Yeah, probably this is the last meeting for this year. So yeah, Happy New Year, everyone. Thank you.